Good morning, everyone. I hope that you're doing well, and welcome to our first biopsy conference of 2023. So without further ado, let's start the cases because we're a little bit behind in the time. So the first case is going to be about a 37-year-old male with past history of seminoma who has received auto-PBST, and Dr. Malik will be presenting the clinical part for this case.
Hello, can you all hear me?
Yes.
Okay, great. Thank you, Dr. Najafian, for this very generous 3-slide allowance. I'll try to do my best. So we have this young man, 37, with no specific past history, as you can see. So his troubles began in May 2020 when he had experienced about a 60-pound weight loss by that time and started having some chest and flank pains. So imaging workup eventually showed left testicular mass with a lot of retroperitoneal adenopathy and bilateral pulmonary metastases as well. So by June of 2020, he did get his orchiectomy, and that confirmed the seminoma that we're talking about. So that was followed by 2 courses of chemo. The first one was July to November 2020, as you can see, bleomycin, etoposide, cisplatin, and then followed by a little change with paclitaxel and ifosfamide with cisplatin. So this chemo regimen cycles led to some stabilization of his disease process, some reduction in his adenopathy and lung metastases, and it was considered that he is overall stable to move toward an autologous stem cell transplant. So he got that transplant in April 2021. So next slide, thanks. So then began a series of hospitalizations and complications following his stem cell transplant. Right off the bat, after his stem cell transplant, he was hospitalized for an episode of sepsis and hypotension, mucositis, diarrheal volume losses, and experienced an oliguric acute kidney injury, which was considered as a dense ATM, to the point that he required hemodialysis for a good month of May of 2021, but was eventually able to get off of hemodialysis. And some of the imaging at that point also showed that he probably had pyelonephritis as well, because he had an enlarged boggy kidney with some perinephric stranding as well. Well, within the next month, he was back with some fever, hypotension, hypoxemia, sepsis, you name it, a lot of lung and infection issues. Well, stabilized, got out. They were planning for a second autologous stem cell transplant, but that never came around to because of recurrent issues, as I'm going to show you next. So in July, he was again admitted with what they considered as an inflammatory pneumonitis, which they thought was coming from his exposure to chemo drugs like bleomycin and all. So he was treated with heavy immunosuppression with methylpred and etanercept at the time. Somehow improved, and then was back the next month with very atypical kind of encephalopathy. There was some acute psychosis with paranoia, hallucinations, catatonia, seizure-like activity. LP was completely unremarkable. They did a lot of workup, including autoimmune causes. They couldn't find any. MRI showed some cerebral cortex with diffuse chronic microhemorrhages at that time. So they thought that it could have been steroid-induced psychosis because of his July course of methylpred or paraneoplastic encephalitis. Anyways, by December, he went ahead and had a retroperitoneal lymph node dissection. That was his last procedure. Thankfully, after that, for the year of 2022, he did not receive any more chemo, any more treatments, no surgery. But the year of 2022 was marked by a progressively worsening hypertension that had gradually continued to increase his medications for control, and eventually had him on max dose nifedipine and metoprolol, and also a persistent thrombocytopenia and anemia, for which he had been started on maintenance EPO and L-Trombopac for the platelets by the oncologists. Next. So here I've tried to summarize the lab trends since this spans a couple of years. So I've just made some columns, as you can see. starting from his baseline, just pre-stem cell transplant data, which is pretty kind of sort of unremarkable, except for some anemia there because he had undergone a couple of cycles of chemo at that time. Then by early post-transplant period, his creatinine had started to gradually increase. He started to have more hematologic ramifications, but that could again be the result of the all the chemo and the that he got with the stem cell transplant. And then major disruptions in his renal function happened during those series of hospitalizations and complications, including the one with the dense ATN and dialysis need happened in the from April to the September stretch of 2021. And even when he got over that, his creatinine continued to slip to 2 to 2.6 toward end of 2021. And finally, the last year, it continued to creep up from the 3s into the 4s with a urine which was not very active looking at that point, except that it had some protein and glucose, and as you can see, very minimal albuminuria, but with persistent hematologic issues with hemoglobin low and the platelets low. And as I told you, he has been on, it still is on maintenance EPO and eltrombopag. A few more pertinent things I've written down there: pathologist's review of his smears with initially in his April when he had the sepsis, it showed the neutrophilic activation. In December, they did not find any significant red blood cell morphological abnormalities. His rest of the hematologic workup was pretty unremarkable, as including testing for the complement activation. As you can see, the soluble membrane attack complex, as Ashley was talking about recently, and then a whole host of viral workup that all was negative as well. So this is his data. Any questions, I'll be happy to answer.
Thanks, Dr. Malik.
So basically, I just did the biopsy because I was a bit confounded. Why is this young man? Well, we can understand that he had several complications during his hospitalizations, but that was about a year ago. And then why is he now consistently getting worse with almost no help from the labs?
Questions?
So he only got gemcitabine once?
No, he got gemcitabine, but that was very early on in 2020. As his first 2 lines of chemo, not after that.
And at this point, he doesn't have any burden of seminoma? No cancer?
He does have a very controlled disease at this point. That was the reason they wanted to do a second autologous stem cell transplant, but they never got around to.
Okay, so with that history, kind of complicated progressive kidney injury in this patient, what is your differential diagnosis? And if we can have the poll here, that would be great.
Coming right up. It looks like I'm going to have 2 questions on case 1 right now, but feel free to just answer the first.
The first one. So can we see the results live or no? Or
I will share them once I have enough people participate. So far, we have 8 of 73.
okay, so the answers are the differential diagnosis: acute tubular injury, tubular interstitial nephritis, TMA, membranous, infection-related glomerulonephritis, or metastasis to the kidney.
You have to answer both of them to be able to submit them.
Yeah, that's what I'm having as well.
Is that right?
Yeah, I'm not able to submit just by answering question 1. I don't know.
Number
8 other
2,
people.
if everyone just chooses A on number 2, I can, it'll work. And then I can give you question 2 again. So you will have the chance to change your answer.
Okay.
Sorry,
So-
this is just the way it was set up.
Okay,
All right, I've got almost half of everyone participating. I'll give you a few more seconds. It's anonymous. Nobody knows what you write, so go ahead. And
yeah, please
participate.
answer because we need to move ahead and would love to see what you thought about this case.
Okay, I'm gonna end the poll and share the results here.
Okay, so 66% TMA was the first diagnosis. And then after that, we have membranous, and then infection, acute tubular injury, and tubular interstitial nephritis, and membranous, both 11%. And nobody thought that that's metastasis to the kidney. So let's move ahead and see what we're observing. Let me actually. So somehow I apologize because folks are first. Yeah, somehow I missed the first slide that was supposed to show the low magnification. But anyway, at the low magnification, we had substantial chronic injury, at least moderate tubular interstitial fibrosis. And it was showing that it was a good sample of the glomeruli. Something up to 10 to 14% of the glomeruli were globally sclerosed. When we focus on the more scarred portions of the cortex, we'll see that basically there is inflammation with focal activity in those areas. And as you can see, and more closer look, basically we have lymphocytes going into the tubules. So kind of we have a chronic tubular nephritis. But it seems like the main problem it may not be in the tubular interstitium, although what we have in the tubular interstitium is serious. So in the other portions of the renal parenchyma, where tubules were a little bit more preserved in terms of not being completely atrophic, we had quite prominent acute tubular injury with flattening of tubular epithelial cells, loss of Roche borders. In some of those, we see that there are, the nucleoli are quite prominent. Are these viral cytopathic changes or not? Although clinically, there was not much suspicion because of the clinical history. We did perform indeed the staining for CMV, SV40, and adenovirus, and all of them came back negative. Okay, so after going over those things in the tubular interstitium, it seems like the main thing is happening inside the glomeruli. So now it's the time to answer the second poll. So what do you see in this picture? And this glomerulus. So can we have the second poll?
Yeah, give me a second. It just takes a few clicks on my end. But
So if you need to answer the first one, I guess that everybody, or can we have
no,
it separate?
this one
Okay,
will just be the second.
So the answers: MPGN, idiopathic nodular glomerulosclerosis, amyloidosis, Wilson nodules, and lichen. So, okay, I
Is that
think
for the second case?
case number 2. This is not for
Oh.
the one to show the
Yeah,
case
sorry.
number 1 polls.
1 second.
Yeah, and that would be the second question.
Let me change it. Okay. There you are.
Okay. This seems better. So necrotizing glomerulonephritis, acute TMA, chronic TMA, acute and chronic TMA, and acute glomerulonephritis. Okay,
I've got waiting for 50% of people.
all right, let's look at the results.
There we are.
Okay, so most people answered acute and chronic TMA, 46%. And then after that, we had acute TMA and chronic TMA and 14% necrotizing glomerulonephritis. Nobody thought it's acute glomerulonephritis. Okay, so
Dr. Najafin, just before you
Yes.
continue, Dr. Lamonte had a question.
yes.
Oh,
Please.
sorry, I hit that by accident. Sorry.
Okay, all right, that's fine. So let's go over the features. So basically, I mean, this glomerulus, as you're seeing, there is extensive mesangial, meaning that in contrast to these areas, let me try to have my laser pointer activated. Okay, in contrast to these regions where we have the mesangium more compact, in other areas, the mesangium is completely exploded and it's pretty loose, and we have extravasation of red blood cells and red blood cell fragments outside of the capillary lumina. So this is characteristic of mesangial, and we have these accumulation of pools of red blood cells, you know, some inside the capillary, some outside of the capillaries, as I said. Maybe there is some pinkish material that could be fibrinolysis. So this is a characteristic feature for thrombotic microangiopathy. And I would say in this picture, it's predominantly acute, but those who answered acute and chronic, they have a valid point as well, because there's very segmental duplication of glomerular base membranes too. This is another picture from another glomerulus. Similar findings, explosion of the mesangial regions, very prominently mesangial and red blood cell extravasation and red blood cell fragments just throughout these glomerulus. But indeed, in other portions of the biopsy, we had more chronic forms of thrombotic microangiopathy. That means in these areas, you have those mesangial regions that showed mesangial. Now they're more scarred. And more characteristic of that, segmentally, we have clear duplication of the glomerular base and membranes. And even in some regions, you can see there is vague nodular formation. That's one of the things that we can observe in chronic thrombotic microangiopathy. Another glomerulus with characteristic features of more chronic form of thrombotic microangiopathy, you can observe duplication of glomerular base and membranes, certainly. What about the vessels? Did we have thrombotic microangiopathy? We did not observe acute TMA in the arterioles and interlobular arteries, but very focally arterioles showed this kind of onion skin appearance, which is classified under more chronic injuries for thrombotic microangiopathy. We also had focal hyalinosis. As you can see, there is accumulation of hyaline material under endothelial lining of this arteriole, but no obvious thrombotic microangiopathy involving this vessel. And this just adjacent glomerulus that shows again chronic TMA with duplication of glomerular base and membrane. So we have both acute and chronic TMA in this biopsy. By immunofluorescence microscopy, did not observe any immune globulin deposition, so it's not membranous, no infection-related glomerulonephritis. We had some C3 deposition in the mesangial regions, as you can see, and maybe a little bit in the peripheral capillary walls as well. Okay, so now let's move to the electron microscopy. So by electron microscopy, this is the glomerular base and membrane and the podocytes that are on the outside. So this is a capillary lumen, but as you know, and this capillary lumen here is a little bit more normal because you can see a little bit of the flat endothelium, which is fenestrated. But in the other areas, and typically in this capillary lumen, as you can see, endothelial cells are very swollen, and basically you do not observe fenestrations in these endothelial cells. Moreover, there is substantial expansion of lamina rara interna just throughout, some cellular interposition, and red blood cell fragments, just what we had, what we saw very clearly by light microscopy. You can see that correlate here by electron microscopy, and no immune type deposits. Platelets are at work. So as you can see in this picture, glomerular base and membrane, a little bit of expansion of lamina rara interna. And within the lumen, we have a small platelet thrombus. All of these are platelets. And in the other regions, just very prominent expansion of lamina rara interna as a result of mesangial. This is still part of that platelet thrombus. And very focally, we had these ill-defined electron densities present in which were present in the mesangium or subendothelial regions, but really no definitive immune type deposits. Podocytes, as you can see, yes, there is segmental effacement of food processes, but in some other regions, slit diaphragms can be seen clearly and food processes are intact. Another picture from another capillary loop, very prominent expansion of lamina interna and new basement membrane formation. See, this is the darker material that its density is similar to the original lamina densa, is the new extracellular matrix deposition, which is creating that duplication of glomerular basement membranes that we saw by Jones stain. Another picture with expansion of lamina interna and red blood cells or red blood cell fragments extravasating. Instead of being in the lumen, now you can see that they are in the subendothelial space or in the mesangial space. So our final diagnosis was basically acute and chronic thrombotic microangiopathy, diffusely involving the glomeruli, predominantly. And also we had a concomitant acute tubular injury, as you saw, which is at least in part secondary to the thrombotic microangiopathy. Also, we observed that focal tubular nephritis that was kind of like chronic active, as I mentioned, with moderate to severe tubular interstitial fibrosis. So not really from a pathologic point of view with very nice characteristics that we like to share with you guys. But and I would not categorize this as a very complicated case. So there are different mechanisms that are proposed for pathophysiology of transplant-associated TMA. And basically, the main thing that is involved is basically endothelial damage because of different mechanisms, inflammatory mechanisms, as well as complement pathway activation, which plays a significant role in all different kinds of thrombotic microangiopathy. And it looks like that basically neutrophils and nets may play a role basically linking these two together. And there is a three-hit hypothesis about the mechanisms underlying transplant-associated TMA that can be considered. And in this case, I see that Dr. Malik has also ordered different tests for checking for these things. So the hit number one is underlying predisposition to complement activation or pre-existing endothelial injury, which may be related to different basically backgrounds that the patient might have. And even, some may come from the donor cells too. If the donor has had a variant for complement pathway regulatory protein issue. The second hit that is proposed is a toxic conditioning regimen, which basically causes endothelial damage. And then the third hit, which is a toxic, I'm sorry, this is basically, I have to remove that. The third hit, which is superimposing conditions, such as if there is like superimposed infections or basically radiation-induced injury or medications that can be associated with thrombotic microangiopathy. So, Bilal, if you want.
So I could not find the first hit because I sent the alternate complement pathway genetic panel to University of Iowa. Well, it took 3 tries to do that. So poor guy had to come 3 times to give his sample. So they did not find any genetic variations in his that could explain a genetic predisposition to this. So I would assume that it's mostly hit 2 and probably hit 3 there somewhere. So I ended up starting him on eculizumab. He has received 2 doses so far, and I'm really hoping that will kick in and stabilize not just his renal decline, but his constant reliance on EPO and eltrombopag as well.
Bilal, I might have missed this. Was his LDH also elevated?
So LDH in these guys are always elevated. All
Oh.
these cellular malignancies and turnovers
Yeah, for
and
sure.
chemos. Yeah.
In a patient just like this, I've definitely seen a lot of ups and downs, depending on where they are in their course. I don't know if it was even checked because of that.
It was checked. I didn't write it. It was normal or too high actually all the time. And the haptoglobins were checked several times. They were normal.
Okay. So in a case like this, I have a question. In a case like these, what parameters or biomarkers or tests do you use to just follow the efficacy of eculizumab in the patient?
Right. So that will be a tough one, right? So because I'll at this point will only have to rely on our typical renal markers, like if his creatinine stabilizes, his blood pressure starts to not require maximum doses of 2 drugs, and proteinuria follow-up, although he didn't have any significant proteinuria in that regard either. Because as you can see, even before I got involved, the hematology group had done all those workups, the haptos, the smears, the terminal complement, the C5b9, they had sent it out to Cincinnati and all. So all of those came back negative. And so I assume that this is the alternate complement pathway activation is happening at the cellular level, on the cell surface level, and not the fluid phase. So I may not be able to find much in terms of hematologic biomarkers in here, other than just relying on how his renal function is doing. Plus, if, as I said before, if we can stabilize his significant anemia and thrombocytopenia, for which he's still dependent on these 2 drugs.
I have another question too. So is there any difference in terms of risk or prevalence of TMA in auto versus allo transplant?
Right. So I think the standard thinking is that you have myeloablative versus non-myeloablative chemo regimen. So the heavier dose you get, of course, and if you have total body irradiation, and then of course with allogeneic, you follow that up with immune suppressants, including calcineurin inhibitors, and our hematology colleagues love to use this combination of sirolimus and tacrolimus. So we see, of course, I think that the risk for developing these transplant-associated TMA is a little bit more in the allogeneic rather than the auto transplant people.
Kelly has a question. Go ahead.
Yeah, along those lines, you did the genetic panel. Did you test for like nephritic factors or inhibitors? The idea that there could be with the transplant, there could be an immune reaction induced that's maybe responsible for the TMA?
Sure. So as I was saying, there was a lot of logistical issues in getting his samples sent to University of Iowa. It got rejected 3 times because of various reasons that we don't need to go in here. And I think, when I had sent it out, I'd sent it for both the genetic panel and the functional panel. And that functional panel never got done because of these issues. So that's why I don't have an answer for that.
Do you plan to switch him to ravulizumab?
Well, for now, it took me an arm and a leg to get his eculizumab approved. So I'm gonna keep on doing this for a while, for maybe 2-3 months, and see if he stabilizes. And then I can reach out back to his insurance company and see if I can get the longer acting approved.
Other questions for Dr. Malik or me? Okay, so thank you very much, Dr. Malik, for presenting this case, and we move to case number 2. So case number 2 is about 63-year-old male with obesity, sleep apnea, hypertension. It refers to nephrology for evaluation of CKD3 and hypertension. And Dr. Dewalski will be presenting the clinical part of this case.
Great. Good morning, everyone. So this is a patient that I'm following in clinic with Dr. Hazley. So he's a 63-year-old man. He has this long-standing history of sleep apnea, hypertension, and was sent to nephrology for evaluation of essentially a rise in creatinine and what was being considered resistant hypertension. He had known history of hypertension 15, 20 years, but wasn't really fully engaged with medical care and had only been on meds for a few years. Essentially presented to an ED several months before he was seen in our clinic for hypertension, was seen by cardiology, who found his creatinine was elevated and sent him over to a nephrology clinic. The CKD was being attributed at that time to hypertension. So he came to us on lisinopril, hydrochlorothiazide, amlodipine, doxazosin, but was still quite hypertensive. He's adherent to a CPAP. And on history, he was noticing that he was having lower extremity edema that had worsened over the last several months prior to presentation, but no orthopnea, no constitutional symptoms. And in the last year or so, his creatinine had increased from 1 to 1.8 at the time of evaluation. In terms of relevant history, he does not have diabetes. He does have the hypertension and sleep apnea, no relevant family history. He has not used tobacco, no drugs or alcohol use, and his vital signs were notable for persistent hypertension, the 160s to 90s in clinic. Exam was mostly notable for being well appearing, not no JVD, his lungs were clear, but he did have pretty significant bilateral lower extremity edema, which he said had worsened in the last few months. And so when he came to clinic, essentially no further workup had been done beyond a BMP. So urine microscopy, UA, and protein was gotten in clinic. His dipstick was positive for protein in blood. His microscopy showed oval fat bodies, red blood cells, but non-dysmorphic. And then his protein creatinine ratio was quite elevated at 11.7 grams per gram, and his albumin creatinine ratio is 7.5. You can see his BMP there, mostly notable for the creatinine being 1.8, mild anemia, and then triglycerides, or his lipid panel was pretty normal. His albumin was a little low at 3.2. We didn't really have any recent prior baselines, and his A1C was normal. So at this point, a further serologic workup was completed for both nephrotic and nephritic. The hepatitis HIV panels were all negative, ANA, ANCA, PLA2R negative. His complements were normal. The only thing that really came up positive was on his SPEP. His free light chains were a little bit elevated, but not really remarkably so for his CKD. But he did have an IgG lambda monoclonal component detected at 0.3 grams per deciliter on his SPEP and immunofixation. So we tried to increase his antihypertensives to prepare him for biopsy, and then ultimately sent him to biopsy.
Thank you. Questions for Dr. Dawalski?
Karen, had his weight changed over time? Understanding the edema may have contributed, and recognizing the limitations of BMI, you want to share what that is as we consider him?
Yeah, I mean, I think he felt like he had gained some weight, but he's kind of one of these guys who's like, well, I don't eat very well, so weight fluctuates. So it wasn't clear that he had put on an incredible amount of weight that he felt was abnormal, I would say. His weight was 125 kilos. I'm forgetting exactly what his BMI was, but he's certainly on the morbidly obese scale.
Other questions? Okay, so let's move to the poll number 1. What is your differential diagnosis? Primary amyloidosis, light chain deposition disease, FSGS, membranous nephropathy, PGNMID, minimal change disease.
And again, just put A for question 2.
Yeah, thank you.
Submit your poll. Few more seconds here.
Okay, so good. Yeah, there is a little bit more uniform distribution among a couple of these. So primary amyloidosis was the first 30%, FSGS 24%. And then we have light chain deposition diseases and PGNMID at 15%, then membranous nephropathy, and at the end, minimal change disease. Okay, so well, let's see what the patient had on the biopsy. Okay. All right. So this time my low magnification images have not disappeared. So let's take a look. We had two biopsy cores. Basically, they're nicely done. They're cortex, both of them. Unfortunately, as you can see, there is a lot of black, and that means that there is a lot of chronic injury in both of these biopsy cores. A good sample of glomeruli, just by this low magnification that I look at these glomeruli, they do not look normal. So we had 13 to 14, 0 to 14% in different levels were globally sclerosed, and as I said, there we had at least moderate tubular interstitial fibrosis. Now let's take a look. And the first picture is from one of those glomeruli. And I have to say that the lesions were pretty much uniform in this biopsy. So here it comes, poll number 2 questions. What do you see? So basically, what are you going to call these lesions? If we can have the poll number 2. Sure. Thank you.
Give me a second.
Sure. So the first one.
Yeah, I know. It's going to take I have to, because we accidentally did it earlier, I have to do a couple of things here to get it back. Yeah, I think we're just going to.
Should I ask people to write in the chat box?
Yeah, I think I'm not going to be able to get it back.
Okay, that's fine. So I can give you the choices. So the choice number 1 is MPGN. Number 2 is idiopathic nodular glomerulosclerosis. Number 3 is Kimmels-de-Wilson nodules. And number 4 is chronic thrombotic microangiopathy. And number 5 is light chain deposition disease. And so feel free to type in the chat box. Let me take a look at the chat box. Okay, so we have number 1, MPGN, and then we have chronic TMA. Any other? Okay, so I'm gonna move on. Okay, nodular glomerulosclerosis, idiopathic nodular glomerulosclerosis with a question: does he smoke?
No history of smoking.
No history of smoking. Nodular glomerulosclerosis, number 2. Okay. Okay, so that's I think that's a good mix, and we can keep going. So let's see what we're seeing in this glomerulus. So I mean, yes, we have nodules. That's true. We have some nodules inside this glomerulus. They're kind of like uniform. When you look at the other thing, it's also this glomerulus is very hypercellular as well, right? I mean, we have cells inside the mesangium. We have cells maybe in the end, basically in the capillaries. Also, we have quite prominent duplication of glomerular basement membranes here and there. And that's something that, although you can see segmental glomerulosclerosis, segmental duplication of glomerular basement membranes in like Kimmels-de-Wilson nodules, idiopathic nodular glomerulosclerosis, but this seems to be really more prominent than that. And given that we have prominent hypercellularity as well in both mesangial regions as well as peripheral capillary walls, I would more lean towards MPGN, although I have to say that definitely these are in the basically nodular glomerulosclerosis for diabetes or for idiopathic nodular glomerulosclerosis. They are in the differential diagnosis with MPGN in terms of the nodular lesions, that's for sure. And also, similar to the picture that we're seeing here, in some areas, kind of similar to the prior case that we had, the mesangial regions are not compact like in these areas. Like this is loose. So we have an element of mesangial lysis, but also it looks like there are some eosinophilic material in these regions too, which became a little bit more interesting when I took a closer look. So now you can probably appreciate more the hypercellularity that I was talking about, especially you see interposition of these many cells basically right beneath the glomerular basal membrane. So you can appreciate the MPGN pattern more, but also look at these eosinophilic material, these eosinophilic globules. So in some areas under the glomerular basal membrane, kind of I have to say that more aligned with the immune type deposits or the deposition processes that we can see inside the glomerulus. But something that I noticed was that it looked like also some of these are intercellular. I mean, kind of like we can see these intercellular globules inside the podocyte, similar to this one, for example, more frequently. But some of these look like they're inside the cells that maybe they're in the mesangium or maybe they're in the capillary loops. I mean, here maybe you can appreciate one of them better. And in this other glomerulus, yes, nodular glomerulosclerosis, but nodules that are very cellular, really, really hypercellular. So that's why we call it an MPGN. And you can see how uniform in this case is, although in some cases of MPGN, they may not be as uniform as this one. But okay, pay attention to this cell, for example. I mean, this is clearly a cell, and then you can see those eosinophilic granules inside them too. So looking at these with the hypercellularity and things, okay, I mean, we expect to see some stuff inside by immunofluorescence microscopy. But before that, I was kind of curious about those cells that they had those eosinophilic globules as well. So thought that, okay, I mean, these might be macrophages. So let's sustain for the macrophages and see if that is the case. And then because I was also curious to correlate that with the immunofluorescence finding. So this is CD68, the same stain that Abol was asking us that if we can detect the macrophages. This is an example of that. And you can see that, yes, I mean, there are a bunch of macrophages inside these glomerulus, which in the many forms or maybe all forms of MPGN, cryo, and those things, you can see macrophages inside the glomeruli. They do influx. And even like in FSGS, we can see lipid-laden macrophages coming into the glomeruli as well. So it's not basically a structure where it is dispersed from macrophage influx, but it's basically, I mean, that is support that those cells that we were observing were indeed the macrophages, monocyte macrophages. Also, on the PAS, I thought that I would show this stain because that's another thing. I mean, we talked about like in the differential, I don't know if I included amyloid or not, but amyloid can cause nodular glomerulosclerosis as well. But in the diabetic nephropathy or in other cases that can lead to MPGN or nodular glomerulosclerosis, the nodules are PAS positive, similar to this case. In some areas, as you can see, it's loose, and that may mean that we have more mesangial lysis. Okay. So before going into the immunofluorescence and electron microscopy, let's take a look at the tubular interstitial compartment. We have acute tubular injury, again, with partial loss of brush borders. And look at the interstitium. There is a lot of black. That means there is a lot of fibrosis, but at the same time, we have focal active interstitial inflammation. And here in these regions also, it looks like there is an inflammatory infiltrate. In some areas, as you're seeing, the black is becoming more loose. So we have some interstitial edema mixed with the fibrosis, and that means that there is focal activity in the interstitium too. And indeed, by H&E stain, when we're looking closer into those areas, besides lymphocytes and besides plasma cells, that you can identify them by this perinuclear HUF, we can see these cells with pretty red, basically granules, and those are eosinophils. So we have focal eosinophilic aggregates as well. Okay, so again, why there is some, sorry, I have to move this because, okay. Don't know why these are displaced, but that's okay. So this is the immunofluorescence microscopy. And in contrast to like diabetic nephropathy and idiopathic nodular glomerulosclerosis, we were thinking, okay, MPG and immune type deposits, we saw those eosinophilic material. So I really wanted to see the immunofluorescence to show me positive results. It did not. So as you can see, basically the immunofluorescence studies were negative. I'm showing IgG, kappa, and lambda because after we basically saw the light microscopy, as well as putting it together with the clinical history that you just heard, we decided to do protease digestion immunofluorescence microscopy. And that means that, okay, if we have abnormal proteins that they're folded, and therefore we have hidden epitopes that cannot be recognized by the antibodies that we use. So we treat the sections by protease, and so we chop the protein to expose those epitopes that they were hidden, and that can result into basic identification of those hidden epitopes. And this is a very good example of that from this biopsy. So we do this for IgG and kappa and lambda currently. And as you can see, the same pattern, MPGN, very cellular, IgG is pretty positive in the peripheral capillary walls as well as in the mesangial areas. And kappa is pretty negative. And lambda is similar to IgG, is pretty positive. So basically, I mean, that confirms that, okay, basically we have monotypical deposition process inside these glomeruli. Unfortunately, because immunofluorescence, regular immunofluorescence was negative, therefore, I mean, it was pointless to do IgG subtyping in this particular case. I'm also showing you another image of the protease digestion immunofluorescence. And as you can see here, I mean, here we have more of those granules in terms of shape, right? And they are basically showing bright staining for IgG. They're showing bright staining for lambda as well, and pretty much not with kappa. Although, I mean, partially we were seeing that, but this most likely is representing one of those podocytes that we see cytoplasmic droplets in them. So basically, these studies confirm that we have a basically deposits that are monotypical. Now, I would like to go back to EM before going to that electron microscopy thing. And I apologize for the back and forth. I don't know, somehow I'm mixed up the location of these images. Now, this EM picture is from this biopsy. It's not from another one with diabetic nephropathy or nodular glomerulosclerosis. But as you can see, there is a lot of increase in the mesangial matrix. So, and I can see why, I mean, some people thought about nodular glomerulosclerosis, because as you can see, I mean, the nodular feature is quite prominent in this in these glomeruli. And basically, there is a lot of increase in the mesangial matrix, although this patient was not diabetic, and we can talk about that. I mean, in the upper right portion also, it's noticeable that, as you can see, there is some basically changes in the mesangial area. Basically, mesangial areas are loosened, so we have some mesangial lysis in those regions as well. And rarely, I want to say rarely, among all the EM images that we looked at, I mean, these were the only deposits that we could identify. As you can see, I mean, these are pretty good deposits in the subendothelial region. This is the capillary lumen, but, and this is a little bit of basically the higher mag of that. Podocytes show food process effacement, but in the other regions, the deposits were not clear. All we were seeing were like increase in mesangial matrix, and some increase in the mesangial cellularity as well. This is that area with the mesangial that I mentioned, that mesangium is disorganized. Another interesting finding was that some of the cells were kind of looking degenerated. I mean, this is like the podocytes, as you're seeing here, and the nucleus has a pretty degenerative look. And maybe same appearance in some cells. I mean, this is a tangential cut through a capillary loop. So basically, I mean, this cell probably is a mesangial cell, and this is another one. This looks a little bit degenerated, but also the common thing between these two is that we have these dark stained granules inside the cytoplasm of these cells. And there's more here with mesangial. So these are equivalent to those cells that I was mentioning to you and I showed to you. There were no obvious crystalline material inside these mesangial cells, though. But yes, there were darkly stained granules, most likely cytoplasm in them. So, putting everything together, how are we going to classify these findings? So, I stayed a little bit on the descriptive side, but then also I said that what basically I favor. So I called it glomerulopathy with features of nodular glomerulosclerosis and MPGN, membranoproliferative glomerulonephritis, with IgG lambda deposits and infiltration of macrophages, likely containing paraprotein filled granules. So putting everything together, we can make a few comments. I mean, no question, given the clinical history, that this is associated with the monoclonal gammopathy. The findings can best be classified, I think, as PGNMID. However, there are some features that are not quite typical of PGNMID, considering that and the influx of the macrophages with those features, the very prominent increase in the mesangial matrix, which I hypothesize that probably that is also related to what we have as, that mesangializes and injury coming probably from the paraprotein related material. So, I mean, for the PGNMID, I'm not going to spend much time. As the most common form is IgG. In this case, was IgG, but we can, in 5 to 10%, we can have IgM. Less than 5%, we can have IgA. And in contrast to basically other forms of paraprotein related nephropathies, in this form we have only in about 30%. We may have basically paraprotein identified in the blood, and identification of indeed lymphoplasmacytic neoplasm is pretty rare. And the most common is IgG3. As I said, we're not able to do IgG subtyping in this case, unfortunately, but the IgG3 is the most common one because it self-aggregates, it's larger, and it also activates C1q commonly. Very rarely we can have also light chain forms of PGNMID that are reported. So how do you want to classify these? In this particular case, this would be one of those cases that indeed we had paraproteinemia. So it falls into this category that, okay, we had the paraprotein in the blood. And then we suggested that, okay, further workup should be done in order to see if there's any clone or not. And we're going to hear about that work to see if it's going to be classified as MGUS-related PGNMID or malignancy-associated PGNMID. But also there are, as I said, there are, a bunch of them that you can't categorize in any of those because you can't find the paraprotein in there. But it can be triggered by other things such as infections, or it can remain as unclassified. Okay. So Karen, if you want to do the follow-up.
Yeah, sure. So with these findings, we sent him to the Hemon clinic, and he did have a bone marrow biopsy there. And the bone marrow pathology showed actually grossly normal trilineage hematopoiesis without evidence of a plasma cell neoplasm. But then on flow cytometry, a very small abnormal plasma cell population was detected. And that was constituting about 0.75% of the total white cells on the flow cytometry. So with that finding of positive abnormal plasma cell population in conjunction with the renal biopsy findings, it was decided that this was an MGRS, probably PGMID, and he was started on Cyborg D treatment, and that was just started a few weeks ago. So I don't really have any updates on exactly how effective it might be at this time, but he has been started on it.
Okay. Thank you.
Mhm.
Questions?
So you didn't have any lymph nodes on imaging or anything concerning?
No.
Kelly, you can go ahead.
Yep. So, looking at that biopsy, it's not a pristine biopsy, and it, it looks like there could be other things going on there. I know the patient doesn't have a history of diabetes. Was worrying about pre-diabetes. I've seemed to see a lot of idiopathic nodular glomerulosclerosis cases in patients that have this sort of pre-diabetes phenotype, and that the smoking thing, I think people should take that with a little bit of grain of salt. I mean, subsequent studies on idiopathic nodular glomerulosclerosis have not seen that really, really strong association with smoking. But so if this is MGERS, how much does our malignancy associated renal disease, how much of the diseases that this patient has can you attribute to that versus maybe something else?
Yeah, so I can talk about that a little bit. So the striking part for me initially was that by electron microscopy, I mean, the initial immunofluorescence was negative. By electron microscopy also, we did not have many deposits, many immune type deposits. And, where I talked to Leah, I said, oh, okay, I mean, this is a little bit unusual. But as I showed, by protease digestion, indeed, we are seeing a lot of deposition. And we know that in some of the MGERS, the deposits may not be quite basically electron dense. So that might be the case. My hypothesis, as I said, I mean, of course, we can't rule out that this patient had idiopathic nodular glomerulosclerosis. Now, on top of that is, having these MGERS. But seeing that picture of basically the deposition process here, together with the mesangiolisis, those cells that they look by electron microscopy, they look like degenerated cells in some areas. I think that it is also likely that the whole picture is induced indeed by the fact that that abnormal paraprotein is being uptaken by cells in those areas, well, macrophages or whatever, degenerated, causing inflammation, mesangiolisis, and leading to basically this picture. For only idiopathic nodular glomerulosclerosis, I think that this is too cellular. I mean, saying that, okay, there is a little bit of deposition process and paraprotein related glomerulopathy, but the majority of that is idiopathic nodular glomerulosclerosis. I think it's too cellular for that. I don't know if you agree with that or my other colleagues about the opinion.
I would agree with that. I think it is look more like an MPGN picture than a true idiopathic nodular. That would be my vote.
I tend to agree. In the chronic stage of MPGN, you can get nodules that can mimic the nodular glomerulosclerosis of diabetes. So I would agree. I mean, the immunofluorescence is quite convincing.
Yeah, but there was variability. Although I mean, this is protease digestion, and it's part of the variability because of that as well.
Yeah, with the variability question, how many gloms were scoped actually?
Oh, for electron microscopy. Yeah. For electron microscopy, we had, I believe, 4 or 5 glomeruli. So it wasn't. But the immune type deposits were really rare. So, and the number of images, and I, asked for re-imaging too, The number of images that we looked, as I recall, was something close to 30, maybe 20. So it wasn't like we weren't lacking images. And that was one of the things that was bothering me, that the number of immune type deposits are not a lot. But look at this one. I mean, there is variability also. I mean, this is the lambda, this is the IgG, although we are seeing deposits here. But when you look at other areas, I think that there is variability in, you know, how much deposition we have in the inside the glomeruli, and that could be part of the part of the explanation why we're not seeing many deposits by EA.
Well, I just want to thank all of our pathologists for participating in a great discussion. Thank you, Karen, and Dr. Dwolski and Dr. Malik for giving us wonderful cases. Just for the sake of time, we'll have to end things. I did want to let everyone know that grand rounds today is going to be given by Pavan Bhatraju on sepsis-induced AKI. So try to make that if you can. Have a good day, everyone.
Thanks, everyone. And also, I would like to basically apologize, Dr. Struthers, and also Yuan, because they had a third case, but we did not have enough time to discuss that. But thank you very much for participating in this meeting.